whether it's a handheld device or it's a nebulizer, somebody's got to teach the patient, which is what you were talking about earlier.
Exactly.
How comfortable are physicians teaching patients, going over technique of either system, any system?
Well, primary care physicians are not, and fortunately we're not usually the ones that do it. I mean, the study that I think lots of people quote about looking whether it was physicians, residents, nurses, respiratory therapists, physicians were the worst at even knowing how to use all of these different devices, let alone teaching it. So most of us have nurses or MAs who do this. The problem is they don't have enough time. There is, in theory, reimbursement for this. It's very minimal and takes a lot of extra paperwork. And so it just doesn't happen. And that's what we really have to make people feel accountable for. This is just as critical as diagnosing and prescribing the right medicine.
Let me just comment on Barbara. Barbara knows because she's involved with me. The foundation has an app which is free on the app stores, and we're presently in the process of adding things to that app. Anxiety scores, depression scores, exacerbated predictors. But perhaps most importantly, we're going to be adding the ability to look at the different devices, and so that you can sit there, take out your iPhone, show it to the patient about how to use it, and that hopefully will become available sometime later this year.
Does the patient have access to the app too?
We will figure out a way to do that.
So the patient can take out the patient's iPhone and compare it to
Yes.
That's exactly.
You know, I use a lot of YouTube. So I have a computer sitting in the office when I see the patient. So I showed them the device, the placebo device. I said, listen, go to this place, just put that in the YouTube, get a couple of, just watch that. So I have many patients that do that and say, oh yeah, you know, I watch that.
And I think that's very, very helpful, and I agree. But if you do not then in turn watch the patient do it,
yes.
you cannot be sure they understood and incorporated what they saw. And one of the things we all have to do is med reconciliation. That's now basically required at every single visit. So if you're going to do med reconciliation and they're on an inhaler, then it's at least one of those inhalers do the observation. And people say, whoa, wait a minute, they're going to take an extra dose of medicine. Who cares? There is no COPD medicine that taking one extra dose a day is going to do anything bad. So we really need that MA or nurse to observe the technique when they do med reconciliation.
The other thing, and I agree completely with what Barbara just said, but it comes back to your conversation at the beginning, Peter, about the comorbidities. Anyone who prescribes 10 to 12 to 15 medicines for a patient who thinks that they're going to fill 10 to 15 is fooling themselves. I mean, even if you've got a drug plan with a copay, you start multiplying 10 to 15 times the copay, it's a lot of money. And it's particularly a problem in the COPD world because people have the option of cutting back on their activity levels so they don't feel they need the medicines. It's the wrong approach and one that we need to fix, but there isn't a simple answer.
That's that kind of self-normalizing we were talking about before.
Yes.
I mean, we all know about this study, right, that I was taught years ago, which is they tried giving medical students as a test one dose of a placebo once a day for a year, right? And they said, just do this, just take this placebo once a day. And at the end of the year, they collected the untaken pills, and it was about 30% for one pill, once a day. This is crazy.
Well, and in COPD, it's unfortunately exactly the opposite. It's about 30% adherence, 70% you would get back.
Well, I'm sure it goes down as you multiply the number of pills.
Right, it's because of the number of pills, because of the cost, because of all kinds of things.
We do have some advantages with new technology. For example, we now have 3 drugs in one inhaler. The first one is on the market, and 2 more that I've been involved with are coming. And that gives you the LAMA, the LABA, and the inhaled steroid, you know, either once or twice a day, depending on which product you choose. And that's very nice. I think that cuts down a lot. And the costs have been in the ballpark of the duals. So I think that might be, then also you have a product line they all use. For example, one company uses the same type of device for all the products.
Okay.
that could be also another little bit of a help. So
It would be a huge help, wouldn't it?
Yep.
I mean, you've got a DPI, an MDI,
it's crazy,
a
isn't it,
soft
Barbara?
mist, and you do them all in different ways, and how can
Isn't
you
that
even
the-
keep track of it?
That's
You
the
can't-
razor
the
blade
patient
business
can't-
model,
that's
right?
right, yeah.
You give them the razor
exactly,
and sell them the blades.
exactly,
right?
exactly.
You lock them into a product
That's
line.
right.
And in this case, if I hear you correctly, that's not necessarily a bad thing.
Well,
No,
it
it could-
certainly shouldn't be
No,
if
it
they
shouldn't be.
have
It's
the
its
full
uniform.
line. Unfortunately, they don't yet have the full line.
I
but-
knew you were going to say that. I knew it. There's always some little catch.
it's primary care, she knows.
How
World
long-
experience.
If you're going to teach somebody to use a device, and I don't want to cast aspersions on any device, but typically, what would you consider to be an adequate length of time to teach somebody to use anything? Anybody have an idea?
Well, I think with somebody who has COPD, it's going to be at least probably 10 to 15 minutes.
There goes your
first
7-minute
time.
patient encounter.
Oh, it's gone totally. And if I don't do it, and the MA that I work with does, she or he is gone for 10 to 12 minutes. Who's going to put my next patient in? Who's going to do the med reconciliation? There aren't enough bodies in there.
So we need to maximize resources. So patient will come, for example, to the pulmonary function lab to get spirometry. That's a huge opportunity. For the hour over there waiting between bronchodilators, so how you use your inhalers? Let's look into that. I have any problem with this? Because you know, the medications are effective if the patient takes them, and it takes them correctly. If they don't do that, they're not going to be effective.
How common is it, with everything that's going on, you get a patient into your office using the medications incorrectly?
90%.
90%.
What?
That they get
A
right.
lot.
There's
They
a
get
smirk
medication
behind you.
incorrect, or they
My
use-
guess
they
is
know it's
it's
incorrect,
more
yes.
than
Yeah.
that.
I thought you were
I mean,
going
but
to say
it's very
correct,
high.
and I was
No,
going to
no,
figure
no.
out, what are you
No,
doing?
incorrect.
That's
No,
great.
incorrect.
Oh, okay.
Yeah.
90%.
Yes.
Well, it's a lot.
Very often.
I did a study which we published a number of years ago using videos to try to answer your question. First of all, if you're teaching an MDI like a discus or a lipta, you can actually successfully, there's only one step in the lipta, so 3 minutes or less is fairly good. So anyway, we did an objective study. I had a grant for this a number of years ago, and we actually filmed the time that it took for a learned, skilled teacher, it was either RT or PharmD or an MD, and up to a certain point, we would cut it off at 20 minutes. And then we came back and filmed the patient again 2 weeks later. And first of all, with a meter dose inhaler, which is the one that takes up a lot of time, you have to have 7.5 pounds of hand strength to squeeze off an MDI. So people with rheumatoid arthritis and stuff like that can't do it. Secondly, though, again, depending on your educational level and your age, it really was very frustrating. So I didn't think it was 90%, but despite skilled people teaching for 15 minutes, we had a high error rate at 2 weeks coming back and documented by film.